I want to thank the organizers and Melanoma for the honor and privilege of speaking today about melanoma and an overview of the things that are happening. And I can tell you that this is a difficult field because we're sort of here, and what I like to do is end up here. So if you don't mind, we'll do that. And it's interesting because I got this job because I didn't want this job. When I first started as a faculty member, I went to my first job. I was an assistant professor. How long ago was that? I had a ponytail. So, Jeff, everybody laughs when I say that. I don't know why. But my the department chair said to me, "Mike, great to have you here. Thanks for joining. By the way, nobody wants to do melanoma. Everybody dies. You're it." And I said, "Oh my, that's terrible." But there's so much going on now. But there's a reason for this pessimism, because between 1998 and 2011, there was not a single new drug approved for melanoma, not a single one. Right? And so we started in a desert, if you wish. But it gave us an opportunity to do things that others could not do. We couldn't use a standard modality, so we had to learn new things. And so there's some new paradigms that I want to talk to you about. And here it is. We have just cracked the code of how to do this. And I want to share that excitement with you. So the past 6 years, we've had 11 new approvals. And of the 11, the ones in red are immunotherapy. So we lead in this area. This is the stuff which we had to learn. And guess what? It's an outstanding thing, and every world is coming to us. Immunotherapy is now becoming one of the primary ways of treating lung cancer, head and neck cancer, Hodgkin's lymphoma, urothelial cancer, renal cell carcinoma, microsatellite unstable colon cancer, and the approvals are coming quick and fast. So I want to share some enthusiasm with you. The question mark tells you that there's a future ahead of us. I want to share that with that. Why is this important? Because we are talking about nothing short of cure. The ability to take people who have stage 4 widely metastatic cancer and to make them tumor-free and to live a life that's meaningful. And so these are folks, and there's no HIPAA violation. They're on the website. I've met all these folks. In the first rendition of immune therapy with high-dose interleukin-2, these are all 10-year survivors. And what I tell my own patients when they come see me now is that what I really, really want from you, I say, is a 10-year Christmas card. And this gentleman here flew to Los Angeles, where I was before I came to MD Anderson a year and a half ago, surprised me with a 10-year Christmas card, took me out to dinner at his 10th year anniversary. So that's what we're talking about today, nothing short of that. Now, there are two paths in this woods, right? There's immunotherapy and kinase inhibition. This is likewise very effective as well. But I'm going to focus on this side of it. These paths seem to diverge, but we are now, with research understanding, we can converge them. There are now therapies that involve both of these modalities. But I want to focus on here because that's where the action is, and this is where things are truly happening quickly. So let me give you, in the next 6 slides, the University of Texas, MD Anderson course on immune therapy. There's a quiz at the end. You can pick up your certificate and so on and so forth. So how does it work? What's the immune system? Well, it's a system. It's not one thing. It's comprised of B cells, T cells. They come from bursa, bone marrow, and thymus, that's T cell when you're in your mommy's tummy. And they come and mature to make B cells and T cells. T cells are the cells that circulate through the body, recognize bad things, and take them out, basically. And it's a system. Multiple things, right? So so it's not one particular thing, but a multitude of systems which all work together. And its job, as we're all equipped with it, is to recognize what belongs to you and what does not belong to you, right? And so part of what we're doing here with immune therapy is making your body recognize that your cancer does not belong. That's the whole thing. So how do we get an immune response? How does your body say, this does not belong here? What does it do? Well, there are these things called dendritic cells, which are found in your body. They have these long processes called dendrites. They reach right out. And their job is to sense the environment. They are found where the outside world comes in contact with you. For instance, in the skin, you have these things called Langerhans cells. And here we've used a special stain, which makes them brown. Here's your skin. This is the outside. This is keratin, which is the ring around the tub when you take a bath. This is the deep part of it. And here are the Langerhans cells, chock-a-block full. And in the intestine, here the villi, the red, are cells that belong to the dendritic cell system. Their job is to sense the environment, to tell the body when something's not right. So what do? They have these long dendrites, and their job is to sample the environment. They reach out, they grab things from around them, pull it into their body, and then ingest them. And then when they do so, and how they do so is that they sample the environment. They're actively moving. So I'm going to show you a movie in which you are looking at a tumor. The tumor is dark and does not fluoresce under under ultraviolet light. We have marked the dendritic cells with green. So what happens when these dendritic cells are now in the tumor, sampling a tumor, like they do other places. So a tumor with dendritic cells tumors contain dendritic cells which are able to sample that environment. What happens after this is that then these antigen-presenting cells or dendritic cells then move to lymphoid organs and present this to the T cells. It's as if I went to Dr. Gershwin and says, Jeff, look what I found over there, that lady, and you show it to him, like, here's this thing that she has. Is that okay? And you show it to the T cells. And what do they bring? They can bring pieces of virus, bacteria, fungus, parasites, and also things like cancer cell pieces to the central environment. And that's what happens. So how did they do that? Well, here you have in green dendritic cells, and in red are lymphocytes. And what they do is they're sensing and showing to the lymphocytes what they found, right? And asking a simple molecular question. Is this okay? Does this belong to us? Or does it not belong to us, right? And once it activates a lymphocyte, here's one that's moving. Let's see if there's the movie play. The movie does not play, I'm sorry. And it starts moving around. So lymphocytes, which are quiescent, asleep, move around. And what happens? How did it go from the lymphoid organs to the tumor? What do they do? So here is a tumor. It's dark because it's not marked to fluoresce. It doesn't naturally fluoresce. But we have marked the blood vessels in red, and we have marked the lymphocytes in green and yellow. And what happens is that, watch the dance. Here's a lymphocyte inside the blood vessel. It knows it's in the tumor right now. It's doing a limbo dance, sticks a foot out, bam, it's out. So that's how it does it. It senses where it is, stops, and finds a way to leave the blood vessel into the tumor. So what happens next? You're in the tumor now, and so these lymphocytes, which are now activated, they're no longer quiescent because that antigen presenting cell gave it a signal. Something here doesn't belong. It activates that lymphocyte, and these are lymphocytes which are chock-a-block full of these chemical grenades, so contained within it. So how does it do its dirty deed on the tumor? Well, here is a lymphocyte, here's a tumor. It actually senses it. It puts its hands on it, frisks it down, says, are you the good guy or the bad guy, right? It's been educated to recognize a bad one. So what happens when it finds a bad lymphocyte? It does this. Injects a chemical grenades in, implodes the tumor cell down. Right there. Upfront, personal, in-your-face type of killing. That's T-cell killing. So you have now had the entire rendition. So let's do it in one slide. The tumor is inside the host. It has molecules that are part of the tumor. These molecules are shed, picked up by these dendritic cells. These dendritic cells then ingest them, take them into the central sort of lymphoid system, where, like a lymph node, where the lymphocytes come, which are resting, and they interact with it. Now, this does it in two ways. The molecule which picks up is presented in a context of MHC, right? So this is multi-histocompatibility complex. What it really says is, here's what I found, here's what I look like. Here's me, here's not me, and presents it to the lymphocytes. And this CD28 is an on switch. So when it presents antigen, it says, hey, guy, wake up. Look at this. Wake up. Look at it. And if it triggers a response and the lymphocytes recognize as say, hey, this doesn't belong here, it will activate. It will move out of the lymphoid organ. It will grow. You have lots of them. And not only do they grow, these lymphocytes are chock-a-block full of these chemical grenades. They have this upfront recognition. And I'll remember now, this molecule here is the same molecule recognized. So it's a really precise system. And once it does that and recognizes that this is the bad guy, it will release a chemical grenade and kill it. This is a potent system. You don't want this running amok in your body, so we have really robust checkpoints built in. These are things in your body which naturally put a damper on it, because you don't want to be eating a salad and something that not exactly doesn't belong to you. You don't want to trigger a response. You don't want to be, always, this is tree pollen time, and so, triggering your immune system. So it possesses these very powerful checkpoints. One of them is called CTLA4, and then one's called PD-1, and you'll recognize these are targets, CTLA4 for Yervoy or ipilimumab. PD-1, there's a host of drugs, but the most The two first ones that came out are Keytruda and Opdivo, also known as pembrolizumab and nivolumab. So these are potent checkpoints in which they say, all right, not so fast, cowboy. Take a look carefully, and it puts a damper at the same time. So you're pushing both at the brake and the gas. So your body is intricately balanced in that way. And we have recognized that these are the same mechanisms which tumor cells can use to get around the immune system. So that's why we have drugs developed against both of these systems here. Now, I want to talk to you, I'm going to skip the entire part about what it can do, but get to the good part. The good part is that there are words that we have never used in immunotherapy. Words like works fast. Why? Because your immune system has to trigger. It has to take time, right? You need a series of vaccinations to get to the point where you are. So, and of course, we think the immune system can work, but we never think it works that efficiently. But we have learned that by manipulating these drugs, and the most potent way of doing it right now is to combine both the anti-CTLA-4 and an anti-PD-1. So nivolumab, pembrolizumab was part of a clinical trial that's published. Here is the reference. So all my slides have references. You can look at the primary, and I'm very happy to provide this as well if need be. And what this is, and I promise, Jeff, I'm only going to show a few of these slides. Oncologists love these slides. So this one here is called waterfall slide. What is a waterfall slide? Every line is a patient on a clinical trial, right? And you ask a simple question. What is the best thing that happened to that patient? If the line went negative, it means that the tumor shrunk. If the best thing that happened was, unfortunately, it went positive, in other words, it grew. So even from the worst seats in the house, you can see in this clinical trial, the vast majority of patients, 80+%, had some control or shrinkage. We draw an arbitrary line at 30%. Why? Because we, as oncologists, have agreed if you get better than 30% shrinkage, we call that a response, right? So when I pick up the phone and call my colleagues in any part of the world, I said, hey, but I have a response. I don't need to go through and say, what I really meant was I measured these tumors. No, we automatically know you got to have a 30% decrease in the sum of long diameters. It's a mathematical calculation. This is the line. Almost every patient had a response. 100% response means it went away completely, right? Look at that. So even from the back of the room, you can see that most patients had a response. It was, and not only that, if you look at this graph here, so this is called a swimmer's plot. Again, I promised Dr. Gershenwald only one of these slides, because we love this. You go to an oncology conference, it's like this all day long. 8 hours of slides like this. Each line here is a patient, and we ask a simple question. What is the thing that happened to them during the course of their treatment? An arrow means that they're still on treatment because their tumor continues to respond. No arrow means that they're no longer responding, so the tumor may have gotten bigger. And the dot means when did we find out they were responding? And I want to show you that the vast majority of patients are responding, not surprising because you know about this, but not only that, the first CT scan done at 12 weeks showed this, the very first CT scan. So this is combining both these immunotherapy together. This is the uber way of doing it. Now, of course, there's a downside to this. This is particularly toxic, and we have to be carefully selective about our patients. And I'm not going to show you those slides because we have a whole bevy of folks that are going to talk about side effects, and I'll have a few side effect slides here too. But the important thing is I've shown you the tremendous possibilities that can happen with immune therapy, right? This is the new way of doing it. We have, unfortunately, unleashed a Pandora's box. There's a reason why we have these systems built, these checkpoints built into our system, right? They are to dampen what your immune system can do to you. So we have opened this Pandora's box, but we've got anti-cancer immunotherapy, but we also have autoimmunity. You induce an immune response, and in doing so, autoimmunity now is the new toxicity. This is the stuff we have to teach all our new students because it's the stuff that's happening. Here are 3 examples. This is a CT scan of an individual. They're lying on their back. This is the right-hand side, this is the left-hand side. Their head's going into the board, their feet's coming out towards you. This is a slice through just the mid part of the chest. And what you're seeing is this sort of area called pneumonitis, inflammation of the lung. These parts of the body that are open to the outside world have also likewise potent checkpoints built into them, and we can unleash inflammation of the lung called pneumonitis. Here is a CT scan of the abdomen right through the belly button. Here's the belly button right there, so it's slicing right through someone. And this is the colon, which is unfortunately dilated and swollen, so this is colitis. And of course, there are things that I had to go back to the textbook to learn. There's a gland in your brain, right between the eyes, just right immediately behind there, called pituitary gland. And glands, we found, can be inflamed during immunotherapy. This is called hypophysitis. I have to tell you, shamefully, that when I saw my first case, I went to my office, closed the door, pulled the textbook off the shelf, and had to read about it. So these are things which we had to learn. You're going to see lectures in this session about endocrinopathies and other side effects that happen. This is an article by Jeff Weber looking at what happens on the first immunotherapy that came out, which is ipilimumab. And ipilimumab is given once every 3 weeks for a total of 4 treatments. And this is a chance of getting, this is the toxicity grade, how bad a side effect can be. Higher it is, the worse off the toxicity. This is when it can happen. And you know, I always say the first dose of immunotherapy. Now, ipilimumab is not used that much these days, but that was our first immunotherapy. That's where we cut our teeth. Here is, I always tell my patients, you know, the first dose is a freebie. Very few chance of side effect. But after that, now we're talking. And there are a couple of things to learn from this. One is that it can happen at any time during this course, right? Mostly after the second infusion. It can happen even after the last infusion, which is inflammation of the pituitary gland. And so, you know, the side effects can be, the onset of side effects can be unreliable as to timing. And when does it go away? So you're not meant to read the fine print. This is, everyone has toxicity here. Toxicity is all gone away, and how fast you drop tells you how fast people with this toxicity drop to 0. Each of these is 3 months, so first quarter, second quarter, third quarter, 1 year. You'll see that some toxicities come down very quickly and abate, like GI toxicities, liver toxicities. Others may hang out for a while, like endocrine toxicities, and this is, I'm sure, a subject of discussion in the next lectures coming up. So what about side effects? Well, let's talk about that. So oftentimes they can present as fatigue, and to pick that as an example, and that can have multiple causes: neurologic, endocrine, cardiac, nephrologic. This is all with checkpoint therapies. And of course, these can manifest as things like peripheral neuropathy, Guillain-Barré syndrome, encephalitis, panhypopituitarism, thyroiditis, adrenal, pancreatitis, myocarditis. And itis is Latin for inflammation. So now you get the sense you can inflammation in multiple tissues, and to make your life interesting, you can have sometimes hyperfunction or hypofunction of some of these endocrine glands. So in some ways, we've had to become better internal medicine doctors, because really picking this up is difficult. But here's the stuff that really makes me pull my hair out. Right? Each individual can have multiple toxicities. So it's not like they have, oh, gee, you have only thyroid. Good, we're good for now, and then walk away. You got to be vigilant through and through. So this is a difficult area in which we have to be very vigilant, and one which we detect in partnership with the patient, because these are hard to detect. Now, the thing about immune therapy, unlike any other therapy, is that there's no direct impact of this therapy on a cancer. You can say, hey, wait, what's this thing here? Well, it doesn't. It works on you, on the body. The condition of the host and any factor that impacts the host's ability to mount an immune response will impact your ability to mount an anti-tumor response. We're almost there. Right? Immunotherapy is not about how many people shrink tumors, about long-term survival. This is called a mathematical curve. And, you know, if it's flat, it's mathematically you're cured. We want more. We want more. We're not happy. And you know this graph. I want to show you that these are all clinical trials, some working in this part of the body, this part of the body of the immune system, all very new checkpoints coming up. There's a lot of excitement in this area. We've got lots to do. I will finish with my patient. 44-year-old radio DJ, on-air seizure. Unfortunately, found to have a brain metastasis on MRI of the brain. Stage 4 melanoma everywhere, unfortunately. Neurosurgery, gamma knife radiation, MEK inhibitors, lung resection. She had 7 gamma knives to the brain to get her brain mets, the poor girl. Pembrolizumab therapy, Keytruda, 2015. And it was no evidence of disease at 6 months, total treatment time, 18 months. This is a picture of her, right? She cycles every weekend. She does, and on the back of her jersey it says, if you're reading this, you've just been passed by a girl with stage 4 cancer. That's where we're at. So I thank you again for the opportunity to speak to you, and I look forward to your questions later on in panel.